All right.
Anna. Well, welcome to our Lunch and Learn, our first Zoom Allied Health Conference, and from the Louisiana chapter of the ASMBS. I encourage all of you who are not members to join the ASMBS and our state chapter, if you're not already. The chapter is working on a number of things, certainly getting information to our members and teaching our members, or updating our members, as well as we're working very hard with the state to try and get the state to start paying benefits for bariatric surgery for the state insurance plan. We've hired a lobbying group, and if anybody's interested, please let me know. We can get you involved in that process. The state does have the highest number of insured people working for it. And so getting them benefits to bariatric surgery, I think, is a very important change for them. We've been working at it for, a decade or more, but it looks like it actually might happen this year. Our program today was put together by our Allied Health Chair and Co-Chair, Marcy Parker and Toya Smith. I'm going to introduce Marcy, who's been our chair of Allied Health now for a number of years. And she's been working very hard and put together this meeting for you all. So I'd like to thank her very much for doing that. She is the bariatric coordinator and dietitian at St. Francis Medical Center Bariatric Program in Monroe. Marcy, I turn it over to you.
All right, thank you, Dr. Richardson. And I'm really excited that we are doing our first Allied Health meeting. We've been talking about this for several years. For us to actually be able to do it is exciting, and I can't wait until we can do it in person. I will introduce our first speaker, who is Dr. Amanda Fontenot. Dr. Amanda Fontenot is the Obesity Medicine Director in the Department of Bariatric Surgery at Ochsner Medical Center. She attended Meharry Medical College in Nashville, Tennessee, and completed her residency in internal medicine at Ochsner Medical Center. Since that time, she has been with the Ochsner West Bank Primary Care Center. She gained diplomatic status with the American Board of Obesity Medicine in March of 2014. She's also a member of the Bariatric Medical Surgery Committee of the Obesity Medicine Association. Thank you, Amanda, for speaking with us today.
I think I'm trying to share my screen here. There we go. All right, so thank you for that introduction. I'm going to talk about optimizing outcomes of bariatric surgery using adjuvant medical treatment. And I don't have any disclosures today. So hopefully within this talk, we'll be able to understand the available treatments for both pre and post-operative bariatric surgery patients, how to target the use of those medications, and then knowing when to kind of employ these strategies for patients in different phases of either the bariatric surgery workup or post-op. So when we say adjuvant medical weight loss treatment, of course, in this setting, referring to people who are also getting bariatric surgery, there's a very broad group of individuals who could possibly receive medical weight loss treatment, not along with surgery. So given that the standards for medical treatment is either a BMI of 27 with comorbidities, or a BMI of 30 or above, regardless, that captures a good portion of the population of Louisiana. So we're going to narrow it down to just those patients also having or who have had bariatric surgery. So when we use weight loss medication, what we're aiming at are different targets along the pathways that control mainly the appetite. We do have some medicines that also kind of target a little bit of the metabolic pathway as well. But what we're trying to do is sort of cut off along the pathway some of the factors that will upregulate the appetite to make it easier for people to work on those challenges that they need to get the habits in place to get their weight down. Medication alone will not just make people lose weight. It is not necessarily motivation in a capsule or a pill. It does require that people still put the work forward, much like we tell people when they're having surgery. If I did have that motivation in a pill, I tell people I just sell it from 9 to 12 and then go home and count my money. But as of yet, it does not exist. So we're basically looking at different targets and where we can cut them off. The surgeons are very good at the targets of ghrelin and GLP-1 and PPY. Leptin, there's been some thought of medications for in the past, leptin coming from the fat cells. But except for a very small segment of the population with some genetic leptin deficiencies, that really hasn't come into play. And then insulin is sort of at the root of a lot of weight issues, plus needs to be controlled to address the weight issue. So it really can trigger a cycle. And so that is also a very important hormone to be looking at. And a lot of that can be done through a person's habits, as well as sometimes using some assistance with medication. And then we also look to the brain, because a great deal of the appetite is controlled in the brain, more so than the stomach or the gut. And so some of the places that we target are the opioid receptors, a receptor called POMC, which is a pro-opioid melanocorticotropin receptor, which is what the stimulants work on. The opioid receptors targeted by one of the more recent medications, Contrave, dopamine, which is also targeted by Contrave. And then there are also some impulse centers that we can work on as well with some of the medications. So basically, we're trying to just cut off some of these different pathways along the point. We know that medications that work on more than one pathway are typically more effective, which is why now we do have some medications that are combination medicines. And although it is not FDA approved to necessarily combine different medications, it clinically is often done. The potential benefits of using the weight loss medications for patients who are getting surgery or who have had surgery. There is increased weight loss that's been shown in the preoperative period, decreased postoperative BMI, the weight loss after having regained tends to be more. For patients that have a higher BMI, which are usually the ones that we may be working with a little bit more for a longer period of time to make sure that their surgery is safe. So BMI over 50 tend to get the most benefits from the medications. And then also, if we start medical treatment a little bit sooner rather than waiting later, so BMI greater than 36, patients seem to get more benefit. And this is kind of true across the board for a lot of different medications. It's not particular to just like one class or one group. So a lot of these are papers and studies that have really, 2019, 2020 have been really good years to get some data for kind of the cooperation between medical and surgical weight loss. So it's really exciting to get some of that data. So the anti-obesity medications that are approved by the FDA include some stimulants. The most commonly used and longest on the market weight loss medication is phentermine. And then since 2012, we've had some newer medications come out, but the ones that remain on the market currently are all just repurposing our combinations of medications that were already in use for other things, which in a way is really good because safety-wise, we know a lot about them. We know about those components. We know that people have used those medications for depression, for headaches, for seizures, for diabetes. So we know a lot about the safety profiles of those medicines, and we're able to kind of confidently use them and know about them. I also think it's really important to think of it in that way as far as decreasing the stigma of weight loss medications. If you think about where the medications work in the brain, how they work, and would you use those medications for a patient with another medical problem, why are some physicians or even some patients hesitant to use them for weight loss? And so I think that it is kind of good that we have a lot of that data with these medicines from, decades even before for some of them. Naltrexone and bupropion, as I said, it does work some on the POMC receptors and opioid receptors, which to some patients sounds a little odd, that we're talking about opiates in the context of weight loss. But I just explained it to people that the part of your brain for drugs, for alcohol, for food, it's all in one central location. So it's not that we are implying that they are using drugs or anything like that. These patients, to use this medication, you should not be taking any opiates because it would render them ineffective. But all of those things are wired through the same area of the brain. Phentermine and topiramate together work on a receptor called GABA, which has to do with impulses. So it's a good drug for people who tend to impulse eat, nighttime eat, those kind of issues. There is some around the clock coverage with both of these two, which is good because I find most people evening tends to be more of an issue. And if you use a stimulant, then that it's meant to be worn off by the evening time. So you don't get as much effect during that period. And then it combines that effect on GABA and carbonic anhydrase, which is great for people who drink soda because it makes it taste bad for most of them, along with the stimulant effects of phentermine, and you get a boost of the effect on the appetite more than either of the drugs individually, and kind of a balancing out of their side effects. And so that tends to work out well. And then liraglutide, 3 milligrams, which at a different dosing is a different, it's a diabetic medication, but at 3 milligrams is branded and approved exclusively for weight loss, which works at GLP-1 to slow gastric emptying, increase satiety, and decrease the overall appetite. Very good cardiac profile, very good cardiovascular safety on that medication. Because of the slowing of the gastric emptying, can cause some nausea or possibly increase in reflux. But a lot of that can be tempered by keeping portion sizes down, avoiding fried, greasy foods. So it almost gives like a good feedback as long as it's not something too severe. There are some medications not FDA approved, but often used off label, and semaglutide subcutaneous at a higher dose than is currently available will likely be out this summer, hopefully, and should really be a game changer because the results with it, there was an article in the New York Times recently about it. The results of the studies with the higher dosing of it are really, really great. And so that will be really exciting when that comes out. But these are all components of or similar to the medications on the previous slide. So how do you know who should get what? I always explain to patients, unfortunately, we don't have a blood test where I can like draw a lab and say, this is the medicine for you. Can take some cues from getting a good dietary history and psych history and all of those things, that we're kind of doing during this process anyway. And so if it's someone that it's just, their appetite is up, cravings are up, so it's making it really hard for them to stick to making those changes. The stimulants tend to work well for that, along with topiramate, either in combination with the stimulant, or if they're like a cardiac patient and they can't take a stimulant, sometimes topiramate by itself will get the job done. If there are problems with more impulse control, people who just don't have kind of like an off switch Topiramate also works well. And like I said, for nighttime issues with eating, tends to work well. Also, if there's a history of substance abuse, topiramate is sometimes also used. It's used in so many specialties, and sometimes psychiatrists will use it for alcohol cravings. Bupropion and naltrexone, same kind of thing, helps with people who might have a history of substance abuse. And then you don't want to use a stimulant in that particular subset of patients. And so those two offer some safer options. If the problem is fullness, so getting full or staying full, the GLP-1A group of medications is excellent. Topiramate too will sometimes promote some fullness. I was actually talking to a patient yesterday who had a gastric bypass many, many years ago, and I started her on a GLP-1A. And she said, it really feels like right after I had my gastric bypass. And I said, well, good, that's how I want you to feel. But she was really amazed. And I explained to her that hormone is affected during gastric bypass. And so we do hope to get a similar, kind of effect. And I do find that post-surgery patients on a GLP-1A do really well tolerating side effect wise, because I tell them, it'll feel like when you first had surgery. You're going to get that fullness back. You need to follow all the same rules the dietitian gave you with the small meals and the eating slowly. So they seem a little less bothered by that process, or it's a little easier for them. And then for people who may be having surgery later, I tell them, it's kind of a good little test run. It won't be as strong of an effect as your surgery will be when you get it, but it'll help you to get those habits in place. And then if there is an issue with insulin resistance, certainly those people who are type 2 diabetes, we know are insulin resistant. People with metabolic syndrome, sometimes I calculate what's called a HOMA-IR, which is a homeostatic relationship of glucose and insulin. And if it's high, then sometimes those patients can have normal blood sugar, normal A1C, but they have a lot of circulating insulin, which makes it difficult to lose weight because you're basically wanting to store up those extra calories of fat at that point. And so with those issues, GLP-1As will of course work. And then also just sometimes metformin. And I find sometimes metformin gets pulled a little bit too early. And so sometimes it might be actually a matter of restarting the metformin. So when patients have had surgery and they gain weight back, which happens in about 50% of people, there can be, some reversing of some of those health benefits that were initially seen. There can be some changes in some of the gut hormones that could be correlated with that possibly. And then also sometimes changes with body composition. Of course, if you can maintain more muscle mass, people tend to do better maintaining their weight. There's been some things that look at if people who get removal of the excess skin do better maintaining their weight, and there might be a little bit of an advantage there. But I don't know if it's enough to say that that part is really statistically significant. So there's been different studies looking at weight gain after surgery. And the trends are pretty similar, like bypass patients have a little less weight regain versus sleeve patients and versus gastric banding patients, kind of also proportional to what you see in terms of weight loss. And then why do people gain weight back? Well, keeping weight off is really hard, what I would say is the number one reason. And then, of course, if they are getting back, some of their more appetite and cravings, which leads to increases in the amount that they are taking in, the changes in some of those gut hormones, that's such a strong effect initially, and then feeling some of it wearing off. The activity level, definitely the average that's been shown for any kind of weight loss to maintain it, no matter how you lost weight, is probably about an hour a day, which is a pretty high bar for a lot of people. And so, if someone then gets an injury or a surgery and they're down and out for a while, or they just have, not kept up with their exercise, and that definitely can factor in. Maybe they've been started on some medications that have caused them for some weight gain. And then of course, I'm sure it's the same everywhere, but I just feel like working in this area where it's just, one thing, if it's not a hurricane, if it's, not a flood, if it's not something else, just so many stressful life events that can kind of trigger people to get off course. So medication wise, to look for different antidepressants, anti-epileptics, the sulfonylureas and thiolidozones, which are diabetic medications, doses of insulin. I mean, ideally, we're getting people off of insulin, not on more insulin. And again, sometimes the cutting back of the insulin is not aggressive enough, and then a person could be eating to keep up with hypoglycemia. The Depo-Provera injection for birth control, fertility treatments, steroids. Some of the sleep medications, most of the sleep medications they're not great in terms of weight, and can sometimes be associated with eating more at night, and then beta blockers as well. So if there are options available to change those for something more weight neutral to negative, that's usually a good look through. And then when it's a situation of regain, does that help in terms of the medications that we use for weight loss? Getting the appetite and cravings down to get people back on track with their dietary compliance, their good bariatric diet, low carbohydrate, high protein, getting people that fullness back, like that patient I mentioned earlier, possibly inducing a little bit of dyschezia or bad taste with certain foods, which topiramate is good for. You have someone and they've come in and they've gained 20 pounds and they tell you they're back to drinking soda, get them off the soda. It also works with beer, I've been told. Anything with bubbles in it. And then also it may make some other foods taste bad. And it's usually things that are very sweet or very salty. And so things that, probably aren't that great for you anyway. Simulating some of those gut hormone properties. And then some of them might have some secondary benefits for like fatigue, the insulin resistance, mood issues, depending on some of the medications. And so combating some of those things to help the patient kind of get back on track. So some of the weight regain you can see can be seem to be, I don't know if it absolutely is, but there seems to be some correlation with some of the gut hormones. Gastroinhibitory polypeptide is one that seems to be higher in people who maintain their weight and lower in people who gain weight back. There are some different points at which GLP-1 tends to peak a little bit higher and then drop lower. So it's a less steady, kind of state, and then getting down to a lower level back at baseline for people who tend to have regain. And then one of the variants of polypeptide, again, tends to be a little lower in people with weight regain. So it's been a really exciting year or two as far as getting a lot of this information. The committee that I'm on within the Obesity Medicine Association really is looking for ways for more relationships with obesity medicine doctors and surgeons and surgery programs, and how we can all work together and kind of, comprehensively tackle the problem of obesity. And we know if we do that, then everyone is healthier and happier usually. So that about sums it up for me. And I'm going to try to unshare. And there we go.
Thank you, Dr. Fontenot. I think it's really important right now. We have a lot of patients that have faced weight regain with the pandemic, either from cravings or from stress eating. And I think you've really put that focus on working with their primary care doctors or working with the surgeons to see is using medication a possibility for those patients as well. So thank you for reminding us all of that. If anybody has questions, we do have a chat box that you can put those questions in, and then Dr. Fontenot and Sheila will both answer those questions at the end. So our next speaker is Sheila Alford. Sheila is the bariatric coordinator for Our Lady of the Lake Regional Medical Center in Baton Rouge. She's a registered dietitian for more than 10 years at Our Lady of Lake. She completed her degree from Louisiana State University and her dietetic internship at Southern University. Sheila is a preceptor for the Franciscan University Dietetic Internship and was named the Baton Rouge Preceptor of the Year in 2019. She's a member of the Baton Rouge Academy of Nutrition and Dietetics and the American Society for Metabolic and Bariatric Surgery. Sheila is going to talk for a minute about using social media during the pandemic for support groups. I know as coordinators, this is something that we all struggle with. So Sheila's going to share some of her experience with that.
Thanks, Marcy. Screen shared. Okay. All right, so really I'm just going to kind of talk through my experience over exactly the last year and how we transitioned from doing in-person support groups to virtual support groups, and then a bit about our outcome and what we can expect for the future with our program. So first, let me start about telling you beforehand what we were doing before the pandemic. We would hold monthly in-person support groups. I kept this consistent with the date, time, and place. I would send emails out ahead of time to draw engagement. And our average attendance was very low, about 5 to 10 people. And our annual surgical volume is around 120 patients per year. So I obviously had challenges with the low attendance. Our hospital is located in the heart of Baton Rouge. Our support group was at 6 p.m. right at rush hour time. And so I found that people probably found it difficult to get in and out of the city at that time. Also, holding the in-person support groups did limit us to having local patients attend only. So prior to the pandemic in March, I had already held our support group that first week of March before we knew anything about what was going to happen at that time and what we faced in the next few months. But once April came and I was working from home, I had limited hours. We had uncertainty about how long we would be in this situation. I had no access to my office phone. I had no communication at that time through our electronic medical record. And at that time, I also had no support, Facebook support group. So really all I had was email to communicate with our patients. So in April, I kind of panicked, sent out some emails to the patients and felt like I wanted to express to them that we're still here, I'm still working. If you need us, here's my email, reach out to me. So I just sent them some resources in an email form. In May, once I realized that we weren't going to be back at work, at the office soon, I decided to open up a Zoom support group, and I had sent out an email ahead of time with a link. And actually, I think I sent out a little survey to the patients, kind of seeing who would want to attend. And I think I had a good amount of people answer that survey. And to my surprise, I had 13 patients join it. So I was super excited because that was a big increase from what we were doing in person. And it went really well. In June, I was actually able to return to the office on June 1st, and our support group was scheduled the very next day, as it usually was on that Tuesday, June 2nd. And I decided to keep it virtual again, since it went well in May, and I didn't really have much time to plan anything at the hospital. So I sent out the email ahead of time, and to my surprise, I had 0 patients join in. So what went wrong? A few things. I think maybe, I was just returning back to the office. So maybe our patients are also returning back to their office. So they were busy, they didn't have time off. They just needed to get to work and get back home. I also realized too, in May, because I was at home, I just went ahead and moved the support group from 6 p.m. to 5 o'clock. And I had a lot of people join in at that time. So I kept it at 5 o'clock in June. But I thought if people are returning back to the office and then having to drive home, maybe 5 o'clock wasn't the right time for them. So July and August came, and the hospital did allow me to return back to in-person support group with limited numbers, but we had a large auditorium anyway, so this wasn't a big concern for me. So I decided to hold the in-person support group, thinking maybe that would draw some more people here. And our hospital was going to screen upon entrance into there to have the patients, still feel comfortable about coming in person. And then I also decided to keep the option to join in virtual in case that patient didn't feel comfortable coming to the hospital just yet. And I found many challenges with doing both the in-person and virtual at the same time, because it wasn't two different groups, it was the same group, same time. One of the challenges was by 6 o'clock, the hospital only had one entrance where they were screening patients, and it wasn't the closest to the auditorium where I would hold support group. So, the patients were having to walk around, go in the main entrance, and then come find us. It was also really difficult to navigate both the Zoom meeting and the in-person group at the same time. I had the patients on my laptop where I could see them on Zoom, but then the patients that I had at the auditorium, they couldn't see the patients on Zoom and they couldn't hear them well, and vice versa. So it was odd and awkward, and I had low attendance once again. So starting in September, I decided we're going to do away with the in-person. The hospital actually had requested, we're going to stop all meetings again. And so I went with virtual only. And I've been doing that since September. And our attendance has only increased starting kind of in December time. And I think this attributes to a few things. Right around the time of September, I was also introducing our new Facebook group, which I'm going to talk about a little bit on the next few slides. I continue to do many engagements through emails. Now that we were back at the office and I was seeing patients, I was spreading the word. We were giving out flyers, and I was telling them about both Facebook group and the virtual support group. And so, so the volume started to grow on support group, but I also can't ignore that our patient volume growth did increase at our own clinic also. So some of the pros and cons that I discovered with doing the virtual versus the in-person, I really like the virtual support group. I use Zoom just like this, and I find it easy to set up. I can share my PowerPoint screen. I can see all the patients on Zoom. There's no driving in traffic, obviously, so it's easy for patients who are out of town to attend. I think patients might be more likely to attend on Zoom since they don't have to drive somewhere. And they can attend last minute. So if they forget or they know they have a limited amount of time in the evening, they can just jump on the call and jump off when they need to. And of course, Zoom is free for everyone. So they don't have to pay any fee for this. Some of the cons of having a virtual support group is that you do miss out on that physical interaction. But I don't feel that you miss out on that personal interaction, because you get to see all 30 patients on the screen at one time and actually see their face, and they can talk back and forth to each other. And I feel like the communication is actually really good between the patients on the support group. But I do feel that for those that may need or want to get out of the house, they're missing that physical time away from the house and meeting in person with other patients. And then this is optional, but there is a Zoom fee for the program if you choose to do so, because the free membership does have a meeting time constraint. So because of this, I chose to pay the fee for the Zoom membership so that we could be unlimited for our time for the support groups. So what do our patients want? Well, I recently created a survey or a poll on our Facebook group and asked the patients, what would they like to see in the future? And as you can see, they love the support group just as much as I do on Zoom. And then a good amount of those patients also chose that they would attend both if offered. And very few would say that they would rather just come in person. So I feel confident that our decision, to do the Zoom and continue with this is a good one. Also had some comments and suggestions from the patients. It seems that they do want to meet in person, and they threw out the option of maybe quarterly. So maybe we can look into doing something soon for them. So let me talk a bit about the Facebook group, because I do feel like this played a big role in our online support group. In the Facebook group, you can get daily activity, and the patients will chat all day long. They can post all day long. It's easy for me to advertise through Facebook. I also continue to send out the same email through the same platform I was using before for patients who aren't on Facebook and for our past patients. But with the Facebook group, I'm able to post just a few minutes before we have our support group to try to draw in more people and just remind them, hey, join me in 15 minutes. I do think people are more likely to check Facebook than they are emails. I know I do. I get a lot of emails. And so the Facebook posts are easier to jump on and check. And you can also set up notifications on group posts. So if a patient wanted to make sure they didn't miss, they can make sure to have Facebook notify them every time we post. There's a lot of camaraderie on our Facebook group. People will comment on the posts, they'll like them, they tag others to join them. So you get that encouragement. And then the patients will also comment after how great the support group was. And so that kind of is advertising, come join us in the next one. So what do you need to know if you're planning or want to set up a Facebook group? I did a lot of research into this, and I didn't put it on here, but I did talk to our hospital marketing team to kind of see what they recommended for us to do. How would they like us to set up a support group? We decided to keep it as a private support group for just our surgery patients. And so you need to determine your privacy. Is it going to be public or private group? And then your access into that group, set up administrators to have people monitor who's joining in the group and then monitoring the posts. Set group rules. This is really important to have. Post often to keep engagement, and then share and spread the word at every visit. I'm a dietitian here at the clinic, so I'm able to, as a meeting with the patients, tell them join our support group on Facebook, and then you can join in on our monthly support group from there. So definitely spread the word, tell your doctors to spread the word. And today we have 195 patients in our Facebook group, and it's just continuing to grow weekly. So it's exciting. So what do I think we're going to do for the future? Well, I think the virtual support group's here to stay. I love it. The patients told me they love it. So I think we're going to continue on with this. And that's it. Thank you.
Thank you, Sheila. I think that a Facebook group that's being ran by a dietitian in a clinic is so important, because they are getting their information from other places. They're joining other Facebook groups. And I think it's important that if they're part of one that you're also moderating and you can see the questions that they're answering, they can get those questions answered in a more appropriate way than sometimes they're getting from that Facebook group that they've joined online. So I think this is very important. I love the idea of the support group online. I know personally here we struggle because we have people that are so spread out. You know, we're in a small town and we have people that drive 2 or 3 hours to come to us. So I think that virtual support group really can be the way of the future for some of these people. I'm interested to see how you do both in the future. So if anybody has any questions, you can ask those questions in the chat group. Both of our moderators or both of our speakers are still on here. So if there's any questions you have, please put those in there. I think, Dr. Fontenot, you know, I'm just thinking about how much a part of medical therapy can go into our bariatric surgery practice. And I think the question I have for that is, how long would you leave these patients on a medication after surgery?
So what we've kind of as a group decided on is some of the medications people can stay on perioperatively. And then if they're not a person where that's necessarily, you know, they don't necessarily need it during that time, they'll be off the medicine. I have instructions for our nurses for 2 weeks before surgery to start tapering medications down. And then past their 6-month visit, if they're not where they need to be in terms of their goals from that point anywhere going forward, then they can be referred back to me at any time. Louisiana does have some strict rules regarding the stimulant medications, but the longer term medications, you can really stay on indefinitely, because I mean, obesity is a chronic illness. I'll usually make out a maintenance plan with patients when they get where they want to be, and then we'll start spacing out their follow-ups, and they'll kind of get a roadmap as to what they need to do or when they need to come back in. But many of the medications, like I said, they've been used for other problems. They've approved for other chronic medical conditions. So we know that they're safe in the longer term. And really, even with the stimulants, they've been around for so long, they probably are very safe in the long term. Just regulation wise in Louisiana, we're not allowed to use them in that way.
All right, thank you. I was curious about that, but good to know that there are some that they can stay on for a long term. Megan Shakesnyder commented in the question and answer, our Tulane Bariatric Facebook group is one of my favorite aspects of our program. Patients love having a quick and easy way to access me as their bariatric dietitian. Thanks for sharing. I agree, Megan. I think any way that our patients feel like they can talk to us or reach out to us or send us questions, I think that's very important for them to feel like they have that easy way to access us. So I agree with that. We have a question from Cynthia Hart. How is the Facebook page monitored by the facility?
So it's really just monitored by me, our clinic manager, and I'm assigned one of our MAs to kind of keep an eye out. So it's just 3 of us right now. And I did have the post to where people could just kind of post freely at any time, but we decided to restrict this and have all posts need an approval before being shared to the page. So most of them I can approve and there's no problem with it. But if I have someone who asks something where we're not sure if we want to share it to everybody, I can respond right back to them, just kind of explain, maybe answer their question or explain why we may not be sharing that to everyone. But it's not monitored by our hospital, just kind of within our own clinic.
Okay, and I think that also answers Suzette's question about who's monitoring the information shared in the Facebook support group. And I think that is smart to have it where you have to approve anything that's posted on there. I think that makes a difference in making sure that misinformation isn't shared.
Right.
And you said there's other people besides you monitoring it, right?
I'm the only dietitian here, and so if it's about information and making sure that they're sharing and representing accurate information, I kind of mostly monitor that. Some other posts that just need approvals, our office manager and our MA will kind of let those go through or leave them for me if I need to see it. So I'm frequently checking it. I can't, I haven't even gotten it on it today yet, but if there was anything that needs to be checked in, I'll check soon and make sure that there's nothing there. A lot of the patients are just kind of cheering each other on and sharing their success, their weight loss, their non-scale victories, all that. So it's really fun to see the camaraderie on there.
I agree. I think, if they've seen you before, then you're the one also answering the questions. I think that is important. I'll give a few minutes for any other questions, but I do appreciate both of y'all speaking today for our first meeting. I think it was very informative for all of us. We'll be sending out a survey soon. Jana will be sending that out for us to kind of see what worked for people. If y'all have other ideas of information that you want to hear about, but also to see if there's other times of the day that might work better. We thought a lunch and learn would be good. Sheila and I both have families, and sometimes it's hard to do a nighttime meeting. So we thought a lunch and learn might be good for our integrated health group. So we'll be sending that out. If you'll be sure and fill that out, just so that we can have some ideas if there's anything else that we can do. We would like to have one more integrated health meeting before the end of the year. So we'll be getting information about that out soon.
I have a question for Amanda. When you're working with the patients and putting them on these medications, how often are they meeting with the dietitian during the process?
So if they're in the workup process, probably at least monthly. If they're like a get back on track, then usually, the dietitian, the PA, myself, we're all kind of working with the patient, and we'll, try to, we don't want to overburden them with the visits, but we'll try to okay, so the dietitian saw you today, check in with Dr. Fontenot next month, and that kind of thing, and they'll be in touch with them. And then we really, my office is directly across the hall from our dietitians. So when we see each other's patients, it's just kind of like, oh, hey, I just saw Miss Smith. This is what we did. This is what we talked about. So it's a pretty fluid relationship. And then how much they need to meet with the dietitian or what have you, we kind of tailor to where the patient is at. And we use, we use the same resources. Mostly I use the dietitian's resources. So we're on the same page and kind of, making sure we're staying consistent.
Okay, thank you.
Thank you.
I think we all agree that multidisciplinary team is so important to have your dietitians, your nurses, your physicians, everybody on board and sharing the same message with those patients. I don't see any more questions, so I will close this out. Again, I appreciate our speakers and all of you that joined in. Thank you for joining us today.